I'm Dr. Fakir Averi, and this is Sexually Transmitted Infections in Adults. Many infections are associated with sexual transmission. Now, these were traditionally termed sexually transmitted diseases or STDs, and currently they are termed sexually transmitted infections or STIs. Now, by calling them infections rather than diseases, we can reduce the stigma associated with STDs and place these infections within the context of a larger sexual health framework. And not all of these STIs will manifest as an actual disease. Now, since 2000, rates of STIs have continued to rise. For example, chlamydia cases have doubled during that time, gonorrhea has increased 40%, and primary and secondary syphilis cases have soared fivefold. And nearly half of STIs are acquired by teens and young adults between age of 15 to 24 years old. The first STI that we'll discuss belongs to the human herpes viruses family. So these are the herpes viruses that contain double-stranded DNA. They're surrounded by a nucleocapsid, which is wrapped inside a tegumen consisting of several viral and cellular proteins, which are in turn surrounded by an envelope which has viral glycoproteins. Now, human herpes viruses are divided to three subfamilies, so the alpha, beta, and gamma. Within the alpha family, we have herpes simplex virus 1 and 2, which, essentially there are 8 of these human herpes viruses that infect humans. So these are dubbed HHV 1, 2, 3, 4, 5, 6, 7, and 8. So the first one, HHV1, is specifically herpes simplex virus 1, and along with HSV1 and HSV2, these are viruses that essentially lead to latency. So once somebody is infected, they will reside on sensory and cranial nerve ganglia, and they will have a period of latency, and they will periodically get reactivated. And the third member of the alpha family is a varicella zoster virus. So, sometimes you will hear the term herpes zoster infection. So it's important to distinguish that from the HSV-based herpes infections. Now, when you look at the seroprevalence among adults in the US, you can see that about more than half of people in the US are actually infected with HSV1, which in general is considered the less severe of the two. And this doesn't necessarily mean that it's is a sexual or genital infection, because HSV1 can also reside outside of the genital area. Whereas, far fewer people, so about up to a quarter of the US adults have HSV2. Now, HSV2 is more likely to cause genital herpes, but regardless, both of these can, either cause infection in the face, orofacial area, or in the genital area. And once, they are there, they will have latency. Other herpes viruses that are clinically important include cytomegalovirus or CMV, which belongs to the beta, and EBV, which belongs to the gamma. However, these are not necessarily sexually transmitted infections, but they do have a role in immunocompromised patients. For this topic, we will focus on genital herpes that's caused by herpes simplex virus. Now, other infections that we will talk about in this topic that are non-viral are chlamydia, gonorrhea, and syphilis. Chlamydia specifically is caused by a typical bacterium called Chlamydia trachomatis. This is an obligate intracellular bacterium, so essentially has to go inside the cells of the host in order to replicate, which, if you think about it, that makes it difficult to culture in the lab, because they have to be inside the cell, so you cannot just grow them on a plate. And there are a lot of similarities between chlamydia and gonorrhea as far as manifestation. Essentially, they infect the epithelium cells, and that could be, in the eye, in the genital urinary tract, or in the rectal area. But essentially, they attack the epithelium. So gonorrhea, in comparison, is caused by Neisseria gonorrhoeae, which is a gram-negative cocci. And similar, a lot of similarities between these two as far as manifestations, because they do infect the epithelium cell, but they are vastly different organisms, and treatments are different, more or less. And gonorrhea in general is considered more severe, and is more likely to cause disseminated gonococcal infection. And disseminated essentially means that everywhere in the body. And resistance is also an issue with gonorrhea, which we'll discuss briefly. Syphilis, which is caused by Treponema pallidum, which is a gram-negative spirochete. So essentially, this kind of looks like a spring, so to speak, the shape of it. And syphilis is a very severe infection in the sense that first of all, it has a multi-stage infection. So it goes from very mild infection to essentially life-threatening infection over a period of time. So it essentially disseminates early during the course of infection and invades the central nervous system. This can happen at any time during the course of the infection. Now, when we look at resistant patterns, in regards to the report from CDC that was published in 2019, you can see that the drug-resistant Neisseria gonorrhea is actually an urgent threat level. And to put it in perspective, there are only 5 organisms that get the urgent threat level from CDC. That includes carbapenem-resistant Acinetobacter, Candida auris, Clostridioides difficile, carbapenem-resistant Enterobacterales, and drug-resistant Neisseria gonorrhea. So this is urgent because when you get this type of drug resistant, we don't have a lot of treatment options. And you can see on this small chart down here that as time goes on, the rate of resistance continues to go up to the level that, over a period of time, we have been essentially losing the treatments that we had as an option. Now, the first learning objective is describe the pharmacokinetics and pharmacodynamic properties of anti-infective agents used for the treatment of genital herpes, gonorrhea, chlamydia, and syphilis. So when it comes to antiviral agents for the management of herpes viruses, the 3 most important ones include acyclovir, valacyclovir, and famciclovir. And we also have some topical options that they're not necessarily used for genital herpes, but when you consider, for example, orofacial, for example, Abreva is something that's available over the counter when people have facial manifestations of HSV, and those are topical, so they're listed here. But I want to focus on the 3 that are used systemically for management of patients with genital herpes. So acyclovir, which these are essentially analogs of nucleosides. So acyclovir is a acyclic guanine analog, and because it looks like guanine, it essentially inhibits viral DNA synthesis. So herpes viruses are DNA viruses. And acyclovir is available as IV, as PO, and as topical. Now, it's important that this is pretty much the IV drug of, in case of severe infections, this is the IV drug to go to. But in general, oral options are the mainstay of treatment. Now, the problem with acyclovir is twofold. One is that, the oral bioavailability is very low, so it's about 10 to 30%, and that's why we have valacyclovir. So essentially, this is a valine ester of the acyclovir, and that valine essentially improves bioavailability. So it actually increases up not to 100%, but essentially up to 70% bioavailability. So that essentially improves that. But other than that, the 2 drugs are pretty similar as far as adverse effects, and of course valacyclovir is not available as IV. Now, when you look at the adverse effects, essentially GI effects, so nausea, diarrhea, but also rash, headache, and rarely neurotoxicity. So, and this would be in the case of, because these are renally clear. So if somebody has renal dysfunction, if they're not renally adjusted, or, just in case of overdose, patients are likely to have neurotoxicity, and this neurotoxicity could include seizures. So typically confusion, hallucination, but could include seizures. And with the IV formulation of acyclovir specifically, it's also a nephrotoxic agent. So because with the IV we'll have high doses, and I emphasize IV because if you think about it, the PO version is only about 10 to 30% absorbed, so you're less likely to get these severe rare adverse effects. But with the IV, which you have 100% availability, you're going to get high doses, and so it's one of the nephrotoxic agents. So specifically it can form crystallines, so it can cause obstruction, but also it can cause interstitial nephritis. So that's one of the types of AKI, and so that's something that you don't see with valacyclovir. And then famciclovir also is a prodrug of penciclovir. So penciclovir is only available as topical, so I'm not really going to talk about it, but essentially famciclovir is a prodrug of penciclovir that improves bioavailability, but mechanism of action is the same. So essentially all of these 4 drugs are analogs of guanine, which inhibits viral DNA synthesis. And here's how it works. So essentially for DNA synthesis, you need nucleic acids. So when you have, you have your 4 nucleic acids, right? So you have thymine, adenine, cytosine, and guanine, and those are what's naturally supposed to be there in DNA. So they will make the right bonds, and as DNA polymers is making DNA, it will make DNA. Now, when you have a compound that looks like guanine, you essentially the polymerase will incorporate acyclovir into the chain, but because this looks different, it's not going to be able to make the appropriate bonds that's required for the DNA. And essentially what happens is that the process of DNA synthesis will be terminated. So that's how these agents will interrupt DNA synthesis. Now, one thing that's important to consider is that before they can actually be incorporated into the DNA, they actually need to be converted to the active form. So they do depend on the thymidine kinase enzyme that comes with the virus. So herpes virus has this enzyme. So essentially acyclovir needs to be phosphorylated by this enzyme, and that's how you get so normally nucleoside will be phosphorylated into monophosphate, and it will continue until the final step where it is incorporated into DNA. So the same is true. So acyclovir and famciclovir and valacyclovir will need to be phosphorylated, and that's something that could happen. So if there are mutations in this enzyme, acyclovir will not work. But pretty much for herpes viruses, resistant to acyclovir has been pretty rare. And just to show you the life cycle of herpes viruses, these are DNA viruses. So once they attach to the target epithelium cell, they will go inside, and then because they're DNA viruses, they actually need to go inside the nucleus in order to replicate. So they will have to go inside, and then they will replicate inside the nucleus, and then it will come outside and will have its other protein products, and will assemble into a virion, and then will release and infect the next cell. Now, some of the antibiotics used for management of bacterial and STIs include aminoglycosides, which we know bind to the 30S subunits of ribosome, and they inhibit protein synthesis. Of course, aminoglycosides associated with nephrotoxicity and ototoxicity. We'll also use tetracycline. Specifically, doxycycline has a big role for some of these infections, which We know they bind to 30S subunits similar to aminoglycosides to inhibit protein synthesis. For tetracyclines, they can cause photosensitivity. And deposition in bone and teeth, there's a question mark here because that was seen with the tetracycline itself, but some of the other agents in this class don't necessarily cause this. So doxycycline is, that's not really a concern with doxycycline. Macrolide, specifically azithromycin, has been used for some of the STIs. So the macrolides are bind to 50S subunit and they inhibit protein synthesis. And of course, with macrolides, QTC prolongation is a concern. The same with fluoroquinolones, QTC prolongation is a concern, along with a bunch of other things, among which is tendinitis, neurotoxicity, and not to forget about all the black box warnings for fluoroquinolones. And fluoroquinolones work differently in that they bind to topoisomerase 2, which is DNA gyrus, and essentially prevent replication of DNA. And last but not least, we have beta lactams. So penicillins, especially for syphilis, penicillin has a big role. And of course, for for example, cephalosporins are also used for some of these. So ceftriaxone, cefixime. So these are essentially, the mechanism of action is the same. They bind to penicillin binding proteins. Now there are different types of penicillin binding proteins. So depending on which one beta lactams bind to, that's how you get different spectrum of activity for different beta lactams. And in general, they are pretty well tolerated. You do get GI upset and essentially hypersensitivity or rash. And in high doses, you can get seizure, and also drug fever is a concern in general, but very rare. Now, here are the three common things when it comes to penicillin, it's important to distinguish between different formulation. So there is penicillin G benzathine, which is brand name Bicillin, which sometimes there is a shortage of this drug. That's used IM, so intramuscular. Now, one thing that's specific about these IM injections, with this one in particular, is that it actually has a formulation where the repository provides tissue depots from which the drug is absorbed over days. So even though you gave a single shot of this in the muscle, it actually will be working over several days, which means that you get a little bit of the drug released every day. Now, it's important to note that this is for IM use only, and it is not for intravenous injection. There is a black box warning that says do not inject intravenously or admix with other IV solutions. There have been reports of inadvertent IV administration of this formulation, which has resulted in cardiorespiratory arrest and death. Another one that's similar to this is the procaine penicillin G. This one was actually discontinued in 2023. So technically we don't have to deal with this anymore, but this was similar to that. So it's a repository that provides tissue depots, and it releases over hours. Now this one doesn't last as much as Bicillin, and it doesn't have the black box warning, but essentially this one is also for IM use only. But then again, it's been discontinued, so we don't have that problem. Now, I'm showing you these three because when it comes to neurosyphilis, and that's specifically syphilis infection that has made it to the CNS, because these are, the IM injections are not going to work because you get a little bit of the drug released over time, which means that you're not going to get enough concentrations in the CSF. So these are not appropriate for neurosyphilis. So what you want is intravenous injection of penicillin so that you can get high concentrations into the CNS. And because this one, aqueous crystalline penicillin G, is short acting, So you can give a higher doses, so that's something to consider when we look at treatment. Anytime you have IV, you have to make sure that you don't do the other formulations.